Welcome to our Wednesday meetings. Today we are going to discuss about an interesting case that we are currently managing here at Hulski Hospital. Okay, so I am not a guru in this topic, but I just thought I could lead a discussion about auditory neuropathy spectral disorders. I am happy, I think, amongst our platform there are gurus in these cases. So I'm just leading the discussion. All the questions will direct them towards the gurus. So the term auditory neuropathy was first used by A. Star in 1996. So it's a fairly recent diagnosis, and there are still lots and lots of things to understand about auditory neuropathy spectral disease. So I'll start with a case presentation. It's an 18-year-old female patient who presented to our OPD in August this year. She presented with progressive hearing loss. And the parents initially were not concerned about the hearing loss. They just dismissed it, and they were hoping that eventually she would catch up. There is no prior history of otalgia, no prior history of otorrhea. There is no history of vertigo. And the past medical and surgical history, no history of any ear operations before. There is no history of HIV, TB, meningitis. She is a firstborn in a family of 5, and other 4 siblings. They're essentially okay. Their hearing is fine. She goes to a conventional school, but she is not performing well. She is in grade 10 and she is 18 years old. But even though in grade 10, she is not performing well. The parents, like I said, they, like most African parents, they dismiss ear problems easily, hoping that one day someone will catch up. So this patient initially presented to Red Cross, I think around 5 or 6 years of age. She was given bilateral hearing aids, which she used for about 8 to 10 months, then she threw them away. So from 7 years of age until August, she was not using any hearing aids. There is no family history of hearing loss. So the mother was well during the pregnancy. She just reports that she was doing lots of manual work. She had preterm labor at 28 weeks, and she delivered a 1,500 gram baby. They stayed in a NICU for about 3-4 weeks, but the mother doesn't recall any injections given to the baby or any jaundice or any other problems during that 4-week stay. The neonatal period was uneventful. The first year of life, again, it was uneventful. The mother noted that the child was the gross motor and fine motor skills. They were developing normally according to the expected age, but she noted that she had delayed speech and language. The rest of the examination was normal. However, when she is talking, yes, she has some speech, but when she is talking, she tends to clinch her jaw. So sometimes you may miss what she is saying. And so she had an audiogram. She had presented a year earlier to our audiology department here, I think in April 2021. And almost about a year later in July, she came back, and that's when she had the ENT consult with us. So I'd ask one of the registrars to take us through the audiograms.
Charles, you should have registered. Yeah. Okay, thanks, Erasmus. So I'm not sure which one was taken.
So the one on my left, which is directly below 6 April 21, is the first one. Then the one below 2022 is the recent one.
Okay, so I'll start with the left one. So this is a Pluton audiogram of the patient of discussion. And it's, in terms of variability, it's a fairly good audiogram. You can see the speech reception thresholds and the Pluton average are within 10 decibels of each other. So there is essentially bilateral mild to severe. I would say on the right, it's a mild to severe. It's a mixed hearing loss, but the airborne gap is insignificant. So I would still think this. I'll call this a more or less a sensory neural hearing loss. And also on the left side, that airborne gap is insignificant. So it's like it's a mixed hearing loss. Also, it's a mild to profound with a very small airborne gap that's insignificant. So I would still call this also more of a left mild to profound sensory neural hearing loss. And then if we look at these speech discrimination scores, the speech discrimination scores are also low on the articulation gain curve, with a maximum score of about on the right side, it's about almost 65 to 70%. At around 65-70%, and on the left is quite very low speech discrimination scores of I think it's about 30%. And yeah, there is so there's not a lot of the whole kind of curves to comment on whether there is plateauing or there is rollover. So yeah, on the more recent audiogram, I think on the right side you can see there is a mild to severe. It's a downsloping, or more or less downsloping sensory neural hearing loss. And on the left is a mild to severe as well, more or less a sensory neural hearing loss. That's mild to severe as well. Yeah, I think it's good variability. This Pluton averages and the speech reception thresholds are within 10 decibels of each other, and the speech discrimination scores are quite poor on the repeat audiogram. Yeah, with maximum score of like 60% on the right and quite like 20% on the left side. That's what I can say.
Okay, thank you very much. Thank you very much, Charles. Yes, so basically in summary, I'll just go straight to the recent audio. The pure tone average is 48, 50. The SRTs again are confirming the pure tone averages, but the main concern is on the articulation gain here. For someone with a pure tone average of 48, 50, word recognition scores are very low. And after being fitted with bilateral hearing aids, I think about a month ago, she had aided results. Again, when I was discussing with the audiologists, they were saying even the aided scores, they are still very low for someone with a speech with a pure tone average of 48, 50, because they've seen patients with this pure tone average almost getting close to 100% on the word scores. So they are still very low. However, I hope if we have an audiologist amongst us, they will help us at the end of the presentation. Okay, so we did an MRI scan for our patient, which was essentially normal. One of the reasons we did an MRI scan was to try and identify the vestibular cochlear nerve. So I think on this axial cast, these are KISS sequence. So we can roughly see a nerve that is going directly into the cochlea here. And almost on the right side again, we can see what looks like a nerve here that is going into the cochlea. So basically, the MRI scan was normal. Again, she has a good fluid signal in the cochlea. I think on the side it are playing here. So far we've done an MRI scan for our patient. We've done speech and pure tones. We are hoping to do ABRs for our patients. We are yet to be able to get to ABRs. I think there was an issue with an ABR machine. I understand at some point when we wanted to get the ABRs, then when she came for the subsequent visits, we discovered there are lots of psychological issues that are happening with our patients. So we ended up sending her for psychological help, and also to try to send them to social worker to try and understand the circumstances behind this patient, because she reports that she's being physically abused, she's being beaten up and down by her parents. She is due for a CT scan, I think end of this month. We are working here towards a cochlear implant. We haven't done any blood workup so far, and if we are to do any blood workup, the question is which bloods are we going to do, and are there any other necessary investigations in particular for this patient? Should we do a genetic workup for our patient? Should we do other investigations as well? So for now, she is fitted with bilateral hearing aids, and like from our audio, the aided scores were taken on the day she was fitted. But the ideal is we want to repeat the aided scores once she has used the hearing aids for some time. So like I said, right now she's undergoing social worker evaluation, and she also being assessed by the psychologist. So we are working with a diagnosis of auditory neuropathy spectral disorder. So a short discussion on the auditory neuropathy spectral disorder. It's a condition where the inner ear detects sounds, but it then fails to send that sound to the brain to make sense to the listener. So it's a hearing impairment that is characterized by deteriorating speech perception despite relatively preserved pure tone detection, and as we've seen on our audiograms. So a bit of anatomy, and I'm sure most of us will remember this the anatomy. So this is the organ of Corti, which is situated in the scala media, and this is our basilar membrane. And in the organ of Corti, we have outer hair cells and inner hair cells. And in terms of numbers, there's almost a 3:1 ratio, outer hair cell to inner hair cell. So there are approximately about 3,500 inner hair cells and about 12,000 outer hair cells. But in terms of neuronal innervation, the inner hair cells, they are innervated more compared to the outer hair cells, because each inner hair cell may get between 10 and 30 neuronal innervations from the spiral ganglion. But for the outer hair cell, one nerve fiber can innervate several outer hair cells. And if we zoom into our inner hair cell nerve junction, we come to our next picture here. So this is the inner hair cell, and these are And this is the synapse, and then these are the spiral ganglion cells. So most of the conditions in auditory neuropathy, they happen on this in this area here. So in auditory neuropathy, the outer ear cell function is normal, is evidenced by the presence of autoacoustic emissions and cochlear microphonics. But the ABR may be absent or grossly abnormal. So there is a division of the auditory neuropathy into a synaptopathy or a neuropathy presynaptic or post-synaptic. Or this division, I think it helps in counseling patients when we want to aid their hearing. And 75% of cases of auditory neuropathy are bilateral, 25% are unilateral, and the auditory neuropathy can be prelingual or postlingual as well. But most of the auditory neuropathy is non-syndromic. So there's just a small diversion. There's a diagnosis called hidden hearing loss. We have to be aware of this concept of hidden hearing loss, where the speech discrimination in noise is challenging, but with pure tone and speech audiometry in quiet. And when we do ABRs, the ABRs are present and well synchronized. So the prevalence of auditory neuropathy is 1 to 10% of the hearing impaired, and 10 to 15% of patients admitted to NICU have a higher prevalence of sensory neural hearing loss, and of those 10 to 15%, 20 to 30% will have auditory neuropathy. And generally all the patients that are admitted to NICU are at higher risk of some form of sensory neural hearing loss, so we have to be aggressive in terms of screening these patients for hearing problems. Etiology of auditory neuropathy is divided into prenatal and postnatal. Prenatal, mostly it's genetic, and some of the studies have confirmed that genetics can be found in up to 40% of patients with auditory neuropathy. Cochlear nerve malformation, cochlear aplasia, cochlear hypoplasia, infections of the mother with measles, mumps, CMV, and the postnatal causes, prematurity, like in the case of our patient, severe jaundice, brain damage from jaundice, mechanical ventilation, ototoxic drugs, and meningitis. So some of the commonly studied genes that in relation to auditory neuropathy is the otophelin gene, and the otophelin gene is responsible for the neurotransmission of the inner ear cells. It helps in the vesicular exocytosis during a neurotransmitter release. So it's one of the commonest genetic mutation that has been associated with auditory neuropathy. There are other genes as well that have been identified. So all these genes cause presynaptic lesions, and generally presynaptic lesions have got a good outcome in terms of hearing augmentation, especially with a cochlear implant. The postsynaptic genetics, the OPA1 mitochondrial protein, which is responsible for the dominant optic atrophy problem, which is either a non-syndromic or a syndromic. And there are also other genes like the ATP1A3 gene, which is responsible for a condition called a Kaposi syndrome, which is cerebellar ataxia, reflexia, phase cavus, optic atrophy, and sensory neural hearing loss. Other syndromes that are related to the auditory neuropathy spectral disorder is the Charcot-Marie tooth and the DDON syndrome. What they have in common is peripheral motor and sensory neuropathy with time. So these patients tend to present later in life, in their late teens. So some of the tests that can be done if we are suspecting auditory neuropathy spectral disorders are pure tones, speech discrimination, supraliminal tests. Supraliminal tests, they study the auditory processing of complex sounds. So they help us in understanding what's happening. Is it auditory neuropathy alone, or there are more to it than just auditory neuropathy? Other tests that can be done are OAEs, distortion product, and transient evoked cochlear microphonics. This cochlear microphonics can be picked when we're doing an ABR or in electrocochleography. We can do ABRs, we can do an electrocochleography, we can do cortical auditory evoked potentials. All these, they help us in trying to understand where the level of the lesion is, and we'll be determining the latency and the amplitude of various waves. ABR, I think from our physiology, we remember it measures electrical activity within the first 20 milliseconds after a stimuli. So the first 20 milliseconds after a stimuli, that's where we record the ABR, and it measures from the 8th nerve to the brain stem. But the cortical auditory evoked potentials, they are slow or late potentials that also measure activity in the auditory cortex. So when we do this test, there are specific waves and latencies that are measured that will help us in understanding where the level of lesion is and what's happening on the auditory pathway. So for ABR in patients with auditory neuropathy, usually we get a flat ABR with no evidence of peaks. We may get an early peaks, absence of later waves, or we may get a poorly synchronized peak with elevated stimuli. This is just a depiction of the waves of and the levels of where each wave is approximately measured. So the 5th wave is measured in the inferior collicus area. So I am not trying to pick up on my teacher here, but you can see there is a Harris. I hate the Harris somewhere. I'm not trying to pick on my teacher, but it's therapy for auditory neuropathy is challenging. There's still lots of things to understand about auditory neuropathy, but generally the principle is trying to maximize signal to noise ratio to improve listening in noise. And there's talk about hearing aids versus cochlear implants. So I think there's a study that was done that had about 260 patients, and 85% were given hearing. 85 patients were given hearing aids, and 49 received cochlear implants. Of the hearing aid group, majority of the patients didn't receive any benefit, but those who received an implant, 85% of them received some benefit. And the principle behind cochlear implant is if most of the lesions in auditory neuropathy, they are presynaptic. And with cochlear implant, we are bypassing these, we are bypassing the synapses. We are bypassing the synapses here, and we are delivering a synchronized electrical impulse to the neurons, which is then taken to the auditory cortex. So that is the principle behind the cochlear implant and why it's reported to be working better. So recently there's a meta-analysis that was done to try to compare if children with auditory neuropathy can benefit from cochlear implants. And the results showed that the results suggested that children with auditory neuropathy who underwent cochlear implant achieved comparable effects in auditory and speech performance compared to children with non-auditory neuropathy, sensorineural hearing loss. So in summary, our take-home message is if you are met with a patient with that you are suspecting of auditory neuropathy, you need to do diagnostic testing, and there are 3 basic tests that you may do: OAEs, cochlear microphonics, and ABRs. And then once you confirm the diagnosis, say the hearing aid trial or consider CI, depending on the development of the auditory skills. And then when the auditory skills are not developing properly, then you may go to a cochlear implant. The discussion is unilateral or bilateral cochlear implant, but this flow diagram will help us in understanding how to manage a patient that you are suspecting to have auditory neuropathy. MRI scans, we do them to try to see if the cochlear nerve is there. But like we said, children in NIP are at higher risk of developing auditory neuropathy. So we need to monitor these children aggressively. And in addition to doing OAEs as for neonatal screening, we need to do ABRs on these children because they may pass with OAEs, then fail on the ABRs. Thank you very much.
Nice, thank you so much, Erasmus. That was very, very cool, very nice case. I just wanted to check if there's any comments from the floor. I see one raised hand. I'm just going to unmute you. Perhaps you can unmute yourself. It's from a 014 number. Are you able to unmute yourself? Silva? Sorry, yes, there, we can hear you.
Sorry, I think the previous hand was a clap I see in the chat. Thank you, Erasmus, for the nice presentation. I just have a couple of questions, and I'm not sure if I maybe missed some of the information just in terms of the case. But I just wanted to ask, so for your case presentation, I noted the audiogram which showed a mild to profound sensory neural hearing loss. I just wanted to ask, for that case, were there OAEs that were done and reflexes and an ABR, or was the patient just referred for those tests, but it hadn't actually been done? It would be interesting just to see what the results of the OAEs, reflex.
Okay. Unfortunately, so far there are no OAEs and there are no reflex tests that we done.
As an ABR was.
Yeah.
In this particular patient.
Thanks, Silva. Are there any other questions, maybe from the floor, Prof, or any comments from any of the members joining us, or from Dr. Harris?
Sorry, Louise, I'm not sure. I think that my connection was broken a little bit. I'm not sure if Erasmus heard my question.
He did receive your question. So it seems that unfortunately there's no OAEs and no ABR done for this patient at this point. So you didn't miss it in the presentation. That information is not available.
Yeah, sorry, if I can just come in here. So we picked up that on the audiogram, when we looked at the thresholds of that patient compared to the speech discrimination, there's quite a big discrepancy. So we referred her for the ABR and for OAEs, but I don't think it was done as yet. When she went on the day she went for her ABRs, we were told that they would have to factor in the severity of a hearing loss to be able to do the ABR. So I just wanted to ask, actually, either if Genevieve is on the call, how the ABR testing would differ in this patient, because apparently because of the severity of the loss, they kind of had to change the way the ABR test was going to be done. So we're still waiting on all of those tests. Those are tests we have to do. We suspect this is auditory neuropathy, but obviously we're waiting on those confirmatory tests to be done. So, but it was just a question for the audiologist. And my second question was, I know there's no single test to tell the difference between hearing loss at the nerve level or sort of at the level of the nerve versus at the level of the cortex. But what are the indicators on those electrophysiological tests that would suggest it's at the level of the cortex rather than the nerve?
Thank you, Tashneem. We've also got Sharon on the call, which is one of our audiologists at Twitter Ski, and we've got another hand raised. Perhaps we can ask Sharon to just respond and then we'll get through the other raised hands. Sharon, if you can just unmute.
Okay, thank you. Good morning, everybody. I just wanted to fill in on the fact of the reflexes. They were done, but they were absent bilaterally, ipsi and contralaterally. And then just to mention that this particular patient is booked today for ABR and for OAEs.
Thank you, Sharon. I don't know if any of the audiologists can address Dr. Harris's question with regards to how you would assess, is there a way to test whether the level of hearing loss is at the cortex versus, you know, she says there's no single test. Are there any physiological tests that can aid with that? I see a hand raised, an 014 number.
Good morning, everyone. Yes, it's me, it's Genevieve. Sorry for raising my hand.
Genevieve, go ahead.
We actually discussed this case I discussed it with Lomi last week. So just so that everybody knows, I'm in no way an electrophysiology expert. I think Silva holds a lot more weight in than me, but I do understand just a little bit about electrophys. So yeah, the patient is having the tests done today, but the main issue that we were discussing was the stimulus level needed to assess the ABR, or to assess the ABR in this case. So like we usually use a click stimulus, which looks at the frequency range from 1000 hertz to 4000 hertz. Now, if you look at the pure tone audiogram and the thresholds, like we would have to actually use a much higher stimulus to elicit the waveforms. So I did some research and we found that you can actually do ABR or a neurodiagnostic ABR with tone bursts. So I think that is going to be our way forward, particularly using tone bursts in the lower frequencies to give us an indication of what the auditory nerve function is like, and then also including DPOAEs and yeah, I think cochlear microphonic or ECOG. The main difficulty that we have at the moment is our lack of capacity when it comes to electrophysiology. So in the past few years, we've lost two of our electrophys experts, Tracy Lee Kluter and Jay Chilhan. So we are in the process of trying to build or rebuild that capacity again, which I think is a limiting factor for this patient, but also for all other patients that come through. So yeah, to answer Dr. Harris's question about the other tests, I think the only other tests that would be able to give you like cortical level responses would be your mid latency tests and your late latency tests, but we unfortunately don't have the capability, the diagnostic capabilities to do those tests at our facilities. You could refer her for a CAPD assessment at our UCT clinic, which they would do like frequency discrimination, so all of those functional tests that can give you an indication of how the auditory processing system works, but knowing already that a lot of those tests are most likely going to be abnormal based on the hearing loss and based on the suspected pathology. So yeah, I hope that makes sense. Silva, if I have said anything wrong, please correct me.
Thanks very much, Unit. Silva, you've got your hand raised. Do you want to respond? Silva, are you there? Is your connection okay? I'm not sure if Silva may have dropped off the call. Dr. Harris, do you have any other comments? Unfortunately, it seems, let's just have a look and see. Dr. Harris, can you hear us? Okay, it doesn't seem either our connection's a bit unstable or the connection's unstable. There we go.
Sorry, nothing from our side. Thanks very much, Genevieve. That's great. And good presentation, Erasmus. Thanks.
Thanks, Tashneem. I just wanted, there's a question from the floor.
Okay, so in this case, would you then put a pan-cochlear electrode rather than a hearing preservation cochlear implant in the case of auditory neuropathy spectrum?
Tashneem, did you hear the question? Erasmus, do you have a comment on that? Do you know, would you know what type of electrode you would opt to place in this patient?
So for these patients, I think we generally they've used standard electrodes, because even the preserved lower frequency hearing thresholds they are not working, because the electrode is going to stimulate the nerve directly. Remember, the problem is at the synapse. So even if they've got a preserved lower frequencies, they are still not delivering enough impulses to stimulate the nerve. So even a standard electrode would be okay.
Okay, thanks, Erasmus. Any other questions from the floor? Any other comments? Okay, we don't see any more questions. Thank you everyone for joining us this morning. Genevieve, did you want to say something? No. Okay. All right. Thank you everyone for joining us. Thanks for a nice presentation. Oh, there is one raised hand. Dr. Lindiwe Nuve, do you want to make a comment, ask a question? You can go ahead. Lindiwe, are you there? Dr. Harris, do you have a comment? Okay, lots of hands going up and down. Okay, I don't see any other further comments. Let's just check our chat function. Check there's nothing there. Okay, in our chat function, it just says, never mind, we've addressed all of the above. Okay, any other questions in the chat function? Any other comments? Okay, thank you everyone. Thank you, Erasmus. That was a really nice presentation. Lots of food for thought. Thank you everyone for joining us, and with that, we're going to end the meeting for the morning.
Thank you. Just the offline.
Hang on.